Hi, everyone. I'm Joan Lunden, your moderator for this session of today's Medical Innovation Summit. We are going to be discussing the important role that collaboration amongst providers played during this pandemic and what has been learned and what the state of healthcare is post COVID-19, so we can find out some strategic ideas about how we keep this collaborative ball rolling, so to speak. And I mean, this year, the pandemic just put an incredible strain and also a spotlight on healthcare executives worldwide. And while no system was too big to avoid impact, no system was too small to make one either. Faced with a crisis, healthcare systems around the globe demonstrated the revolutionary power that collective efforts have on the ability to care for patients. That lofty goal of better, faster, widespread care became a reality as all systems did whatever they could to ensure community health. Today, we have three leading experts from world-renowned provider systems who will speak to the current state of collaboration in healthcare and impart their strategic visions for its secure place in the future. Our panelists include Dr. Gianrico Ferrugia. As president and CEO of Mayo Clinic, he leads one of the largest not-for-profit academic health systems in the US with a 70,000 person workforce and 14 billion in annual revenue. Mayo Clinic is ranked #1 in the nation by US News and World Report. He is also the co-author of Think Big, Start Small, and Move Fast, a blueprint for transformation from the Mayo Clinic Center for Innovation, a book highlighting the need for change in the delivery of healthcare. Also with us, Dr. Ann Klobansky. She is the president and CEO of Mass General Brigham, a Boston-based integrated healthcare system that includes the internationally known Brigham and Women's Hospital and Massachusetts General Hospital, nationally recognized specialty hospitals, including Spalding and Mass Eye and Ear and McLean, and 7 community hospitals, a health insurance company, physicians networks, and community health centers, the largest private employer in Massachusetts with 78,000 employees and annual revenue of $13.4 billion. The nonprofit healthcare system is the nation's leading recipient of NIH funding and a principal teaching affiliate of Harvard Medical School. And Dr. Tom Mihaljevic is CEO and president of Cleveland Clinic, leading an $8 billion healthcare system that includes a main campus in Cleveland, Ohio, 10 regional hospitals, 18 family health centers, as well as facilities in Florida, Nevada, Toronto, Abu Dhabi, and London. He is a cardiothoracic surgeon and has been with the clinic since 2004. Doctors, we welcome you all today, and we very much appreciate you taking the time to share your insights with us. Let's start with the response of the healthcare systems to this outbreak of COVID-19, since it's all we see in the news every day. I want you to talk a little bit about the efforts that your organizations put forth in response to this unprecedented pandemic. Dr. Klobansky, you want to start us off?
Thank you, Joan. So this was truly a galvanizing force for our healthcare systems, around the state and the country. I'd say the efforts very much were the advantage of a singular focus on COVID-19. It took advantage of so many of the systems that we had set up over time. We saw within our own healthcare system an immediate stand-up of our emergency preparedness team. This was critical because what it did is it brought disciplines throughout the healthcare system, whether it was in infectious disease, supply chain management, space management, all of the different disciplines working together in a single team, being able to have a rapid data acquisition, looking at daily dashboards, make decisions in a very streamlined and effective fashion. I would say it also brought together the healthcare systems within the state. So this gets to the widening circle of where this collaboration really took place. So every day, every morning, the leaders of healthcare systems were on the phone with Governor Baker, many throughout the state. we could look together at how we could best use the beds, the ICUs across the city, across the state, how we could transfer PPE, ventilators around where needed. So I think all these things brought us together really to most effectively use the resources and transfer patients and care, not only with our own healthcare system, but more broadly across the state. It also enabled us to leverage technologies that we had not, well, they were not new technologies. For example, digital health, telehealth. And I'll just give you one quick example. We were seeing about 2,000 telehealth visits a month prior to the pandemic. When we rapidly shifted care where it was needed, since the pandemic started, we've now done over 1 million telehealth visits. So all of these things brought us together as a healthcare system and as how we could best provide care across the state.
Dr. Firouzja, how about you at Mayo Clinic? What did you see? How would you characterize it? And what you had in place that might have helped out right in the beginning, like the groundwork, at least for telehealth?
Sure. Let me start by saying that, as you've described, COVID-19 presented extraordinary challenges to all of healthcare. And I'd say up front that we should be proud of how our institutions in general have really responded to these challenges. Mayo Clinic has about 150-year history. So we've gone through a few pandemics, the Spanish flu one, and many others. So we had a team in place that could rely on our mission, our values, including teamwork, resiliency, empathy. That's really part of our DNA. So I believe the best way to briefly describe this is our efforts focused on patients, they focused on staff, and the need for a national response. So starting with patients, we, like every other healthcare system, had to re-engineer how we saw patients over a period of days, shutting down both our inpatient and outpatient practices. And then we had to reopen them in a few days, creating a safe environment. This really meant completely rethinking our points of care, relocating entire practice groups, and really creating a new environment in a matter of days and not weeks. And that, as has been already mentioned, expanding our capacity through telehealth. And we're really pleased that now in the last months, we haven't had a single case of a patient getting infected from our staff and vice versa. From our staff standpoint, we took the step of telling people, okay, we're going to protect your jobs. We're going to ask you to make sacrifices, including financial ones. And I'm so grateful that our staff responded in a way that was incredibly positive. We've since been able to repay our staff for the sacrifices. And I believe the point I really want to emphasize is how much an empowered staff can accomplish without the need for absolute direction. That is really what created a safe environment for Mayo Clinic. And then the national response started off by offering antibody and highly accurate molecular tests, then brought them up to scale through Mayo Clinic laboratories. We're now about 2 million tests that we've done through patients in 48 states. For us, critical, and I know it's been the same for Cleveland Clinic, we set up a COVID-19 research task force. That enabled us to put everything through, be it basic science, clinical trials, healthcare disparity research, through one lens. And so we focused our resources on those high-value, scientifically grounded research. And we have about 300 ongoing studies, about 350 publications. And it's really now gotten to the point where we can look after patients in ways we really couldn't at the beginning. And then lastly, I'll highlight we've led or collaborated on many research studies. That includes the Plasma Initiative that really gave access to about 70,000 people getting plasma in every part of our nation, working with government agencies and with legislators, and really all on the goal of together pooling our expertise to fight this virus.
Well, Dr. Mihaljevic, I mean, we've all been awed, I think, in the public watching healthcare providers, nurses, doctors, everybody that's providing care, you know, what they've done. It really kind of brought it to the attention of everyone. And I know right in the beginning, you said that all of your employees, you wanted them to understand that you were family and you're going to come together. You're going to keep everybody on. And I think that's in part what we saw. It was, as we just heard from Jean-Rico, it's an empowered staff.
Yes, that is true. I think we've all stated that what is really important lesson from this pandemic, and that's the lesson about the importance of those who provide care. We are rightfully focusing on a disease. We'll always be focused on our patients, but I do believe that focus has to be widened. So to say, the lens has to be widened. It has to encompass also our providers, people who are responsible for providing care to others. And there are a few things that our organizations, quite a few things that our organizations that we represent here in these conversations have in common. One is the focus on our caregivers. Second is that we have a very broad footprint, and a big advantage of our organizations that we're integrated healthcare delivery systems. And through that, we can spread the best practices, we can spread the knowledge, and we can accelerate the cures in a ways that is much more effective than it would be if we were small, isolated hospitals. What we also have in common that we have partnered in our own regions, in our own independent states, and have led the efforts of individual states for the benefit of our broader communities. But that collaboration went way beyond our state-based initiatives. They were truly international efforts, national and international efforts. Genrico and I have been on a fairly frequent calls and conversations throughout this pandemic in order to figure out not how do we just respond to what is going on right now, but how do we prepare for the next steps in combating this epidemic, or actually put a foundation for the next epidemic. How can we think ahead of the time and make sure that when the next pandemic strikes us, that we are better prepared and better organized. And lastly, I think this pandemic has also taught us about the richness of our own shared international networks of our friends and colleagues around the world who have contributed with their knowledge, with their experiences. And I cannot overemphasize how important that is. I think what we have learned is the pandemic by its own nature, obviously, it's agnostic to physical boundaries, it's agnostic to cultural boundaries. It affects absolutely every corner of this world. And organizations like ours are really blessed by the fact that we have our alumni all over the world and our collaborators all over the world that have helped us fast forward our progress that we made, I think, in a short period of time in a ways that we understand more about the disease, we're getting better in treating it, and I think we have created more good globally.
Have any of you ever witnessed such a collaborative spirit? I mean, in your time as the leader of a healthcare system?
I would say that there have been many times when we have come together as academic healthcare systems. Certainly when we saw the crisis with HIV, that was a mobilization of many. So for those of us who are leaders of academic healthcare systems, really taking advantage of the incredible depth and research expertise in that area and associated areas, working with, partnering with other academic healthcare systems, that was very clear, whether it was locally, around the state, around the country, or has been mentioned globally. But I think a really important point to emphasize is that of partnerships. So what was a bit different here, and again, this was not new, but it was expanded and accelerated, were not only partnerships within our own academic healthcare systems, with those networks that we've created nationally, internationally, but it was very rapid partnering with government officials, with those in the state, with those at the NIH, with those in the private sector. So this really led to, I would say, very new and rapid collaborations, and also getting beyond a lot of the barriers that have taken a long time to get things done. So that broader ecosystem, and we certainly see that in Boston, just where we are, what's around us, we really were able to take advantage of that, I would say, in new ways. When we think about preparing for the future, we set up a very rapid Mass General Brigham Innovation Center. And again, we do so much in that area, as do other healthcare systems, particularly Mayo, Cleveland Clinic. But it really brought forward people who knew each other, didn't know each other before, with this singular purpose of creating this innovation hub and then using the forces of the broader ecosystem to get a lot of things done very rapidly. And I think in terms of preparing for future pandemics, we've always known that pandemics were going to occur at some point. This is not new. We've all prepared in some ways, but I think what we've learned now is those kind of rapid responses, bringing together all of those disciplines in a very coherent and deliberate way. Those are the things we have to move forward into the future.
Well, that's kind of on a broad base, even small things that had to change. Dr. Mihaljevic, you had the task of taking care of both, your patients and your healthcare providers, both at the same time. And there were little things, well, they weren't so little, but things like respirators that were kept and IV lines and everything that were kept in ICU rooms. I know sometimes things got moved out so that if a patient came in, explain how standard of care procedures had to be changed in order to ensure quick, rapid ability to take care of patients.
Well, all of us had to modify the way that we provide care in order to provide a safe environment, not only for those who we cared for, but also for those who provide care, for our own caregivers. And a really important lesson, I think, for all of us goes back to the Gianrico's point about empowered caregivers, empowered workforce. We actually empowered our own caregivers to help us find out the best and the safest way to take care of patients in the presence of pandemic. And so many innovative approaches have sprung out of that initiative and that empowerment in a short period of time. And the one that you mentioned now in retrospect looks relatively simple and obvious, but it was really transformative in the ways that we take care of, let's say, patients who are in an intensive care unit. To move the intravenous pumps and the control units for the respirator and all other things that we have to have in an intensive care unit outside in a corridor and make it easily accessible for the staff, but keeping it away from a potentially infectious environment inside the patient's room has just simply allowed us to move freely without fear and without actually having a single caregiver who is in an intensive care unit taking care of COVID-positive patients who turn out positive or who contracted illness because of it, which is a remarkable accomplishment in itself. But innovation comes from every corner. And I think our responsibility as the leaders of our organization is to empower our own people to come up with a solution that they see right in front of them. And that's an inspirational journey, I have to say.
And do some of these changes that came out of course, just trying to deal with a crisis like a pandemic, will those things change some standard of care in the future?
Well, I'm certain that we're going to have quite a few changes in the way that we approach care that are going to last beyond the pandemic. I think there are wonderful lessons that we've learned, everything from the use of telemedicine, digital platforms that have rolled fast forward, that have been now well embraced by providers and patients alike. And I think very many of those best practices are going to continue to be best practices even when this pandemic is behind us.
Well, let's talk for a minute then about telehealth. I mean, it played such a huge role in being able to care for those affected by the pandemic, but still be able to serve everyone else, and not to mention to encourage them just to maintain their checkups and to be able to really kind of monitor people who had chronic illnesses. Everyone in the medical world knew that telehealth was coming our way. We just didn't know it was going to happen overnight. Dr. Firouzja, how do you characterize all of a sudden that instant need for telehealth to be up and running full time?
Well, let me start off by saying this is one of the few positives that have really come out of this pandemic. Not many, this is one. All of us had been speaking about telehealth and all our organizations had been creating that infrastructure. But it really took the pandemic to take us over that edge. And that's not simply about licensure, regulation, and billing. I think it's fair to say that within the system, there was a bit of inertia that this pandemic got us over. We went from 800 visits a week to peaking at around 30,000 a week. And we did that over a period of days, which showed us that we could actually do it, which actually meant that we could have done it before. And of course, patients are very satisfied with these visits. I think it's important, however, to point out that telehealth, as we're currently talking about, is really only the tip of what an integrated healthcare model should look like. And that is making sure the patients don't get a choice between telehealth and no telehealth, but rather you can seamlessly go between one and the other according to your needs. So one visit can require face-to-face, but also telehealth. And really goes beyond that first visit, but also to things like advanced care at home. I think this is going to be a very important part that has been accelerated from the pandemic, where patients can receive hospital-level care at home. It's been in development for over a year, but it really took the pandemic to push us to a point where now we can look after patients and not only look after their immediate medical needs at home, but also make sure that their meals are appropriate, that all the other services that allow them to stay at home where they want to be happen. And then, of course, telehealth includes ICUs and all the other opportunities we have to look after patients better. All in all, I would say that for us, it's really building the first true healthcare platform. And so when you take a healthcare platform, you add in it, each of us have centers for digital health, you add these new digital options. What we have now is the foundation to how we can deliver care tomorrow and do it in a way that truly transforms healthcare for the benefit of all. And that is, as I said at the beginning, one of the true few highlights of this pandemic.
Dr. Klebanski, what do you say to those people? There's a lot of people who are kind of afraid of the idea of telehealth. What, I'm not going to actually be there and see my doctor? But the current model, say there's somebody in the Midwest, they get an appointment for 3 months away. Then they drive an hour, then they wait in a waiting room, and finally they go in and they talk to the doctor. Nothing actually happens to them. They aren't, giving them shots or cutting them open. And it's kind of an unsustainable model for an efficient healthcare system. But what do you say to that person who says, I don't know, this is just not the way I've always done it?
So part of it is really change and understanding what that means and the forcing of change and the acceptance of change. I would say from the point of view of providers, and this point's already been made, there really was an incredible amount of reluctance for providers to do these kind of visits for a very long time. And yet, once they started, once there was no choice, there was an enormous acceptance of really how this worked so much better. One could really look face to face with a patient, and patients saw this. It was a very different experience. It was one they had to get used to. But then it became something that I think was really very much embraced. I think the other thing that's important is we are focused very much on care in bricks and mortar facilities, hospitals, community hospitals, clinics. And yet, when we think about this, and this has already been mentioned, the full spectrum of care in the home, what that looks like, what you can actually embed in a lot of these telehealth services, which is, again, the telehealth service of the future, which actually makes for a much better environment for patient care and also will lead to a much higher degree of acceptance. Our providers often talk about the concept of patient convenience in terms of these visits. But if you really think about what that means, it's really a much deeper understanding of patient access, who really has access to these services, what it really means for patients who have to take a day off from work. And you've already mentioned this, travel long distances, wait, park, do all of these things, which really are impediments to healthcare. So these, I think, are things that are all being accepted. And many providers have said to us, for the first time, I actually can see a patient's home. I may actually inadvertently or deliberately see other patient family members who haven't come to visits. So I think all of that is really an important thing forward in the total continuum of care. I would really be remiss if I didn't emphasize the impact on behavioral health. So access to behavioral health is one of our most formidable challenges as a healthcare system and actually as a country. So the very, very rapid response that we could have, not only for patients whose behavioral health needs were in jeopardy, and actually access has been a problem for a long time, telehealth really made a profound difference in that. I would also say to the importance of providing care for our own employees, and not, I would say I would not restrict that to our frontline healthcare givers. It really is, in many ways, all our employees who are facing really significant challenges during this period of time. So having access to embedded telehealth services, that has been very important for those patients as well. And the final point that I'll emphasize, because we've seen this throughout the whole peak of the pandemic, is the incredible highlighting of the communities we serve, the importance of social determinants of health. Those communities with underserved populations, can they also have the ability, have the technology for even these basic services? So we stood up a lot of very basic things, multi-language access, the use of texting, really all of those things that help deliver care, which did not require a lot of technologies, which many would consider available to all, but are really not. So I think all of these things we're focusing on for future, not only current, but also future healthcare delivery.
And I imagine going forward, Dr. Mihaljevic, people come from all over to get, an operation from, a foremost leading surgeon, and then they leave. I mean, I would think that telehealth is going to now create, a platform where you can really, and because they just, walk out and they're out of the hospital. And for that follow-up, I imagine telehealth is going to be critically important.
It is critically important because it is going to provide a much desired continuity of care. I think that is really what we're all speaking about, is that there are certain diseases and disease entities where the episode of care is really, really important. But for vast majority of illnesses that we care for, 80% of our patients are people who we know, and 80% of them have one of 5 or more chronic conditions. They're either obese or have a diabetes or have a hypertension or a combination of all. And what is really, really important is to provide not just a singular episode of care, but a continuum of care, and also be proactive, keeping people healthy. And we oftentimes speak about healthcare after people get ill. Obviously, we're always going to be there for them then, but our joint effort here is to use this technology also to keep people healthy. We want to lean in and be much more proactive and be real partners in maintenance of health, not just be there for curing the illness. And I think digital technology will allow us earlier detection, easier access, and an ability to reach many more patients more effectively and probably more proactively than we have done in the past.
Dr. Farrugia, you touched on serving your communities, and I know the impact on the communities that you all serve is one of the most important things, for any medical provider. How were health and safety efforts kind of, I don't want to say doled out, but spread through your communities and how do you go about shifting your attention and your support to maybe more rural locations, maybe some underserved populations?
So Mayo Clinic has together with our destination medical centers, has a health system. It's 18 regional hospitals, 68 regional clinics, mostly in the Midwest. And therefore, we've always been integrated. We've always been one Mayo. So that part was okay. What we had to do is make sure that the information we had, for example, the modeling to know where the next outbreak was going to happen, which parts of the states we're in were going to experience a surge, made sense county by county. And so we had to be careful that the information we provide is provided in as many languages as possible. We provide all our COVID information in 12 languages. And then we had to develop the tools to make sure that it's very different when you have a large system. But in a smaller healthcare system, losing 10, 20 people in your workforce can really create a stress on delivering healthcare. So we had to flex our staff in order to do that. And that's something we had to learn how to do even more than before that. I'd say that the Midwest is a home to meatpacking plants, it's home to manufacturing, and there are some unique challenges going out to the community. And so we had to make sure we created ways where people felt safe, providing information, getting tested, getting the results of testing, and that the companies they worked for felt also safe making the changes that they need to make. And then we had to move to make sure the same applied to the districts, the schools, so that the whole system benefited from our knowledge. I will make the point that you've just heard us talk about telehealth, rural telehealth, telehealth even in destination medical centers. Healthcare is like a stiff rubber band. And I've said this many times. You stretch it, it stretches when there's tension, you release the tension, it goes back. So it's our job now, it's collectively our job to make sure that we don't go back, that we take advantage of what we've learned, it becomes the new reality, and the transformation in healthcare that we need now happens. Because I would make the point that even though this year has been so challenging, we cannot forget that last year wasn't exactly perfect for healthcare. There are many issues in healthcare. We now have new tools that, as a result of the pandemic, are available. Let's now use them collectively to create a greater good, a greater healthcare system for all.
So in a way, I mean, this has been such a horrible year for everyone in fighting this virus. However, we're here talking about the good that came out from a healthcare provider system. And I know you not only collaborated with each other, but you also collaborated with businesses. Dr. Mihaljevic, I remember you told me that you brought in a partnership with the Amish to, I think, make masks, right?
Yes, we did at the very beginning of pandemic. All of us were concerned about the availability of personal protective equipment, and in an effort to provide sufficient masks, we reached out to our communities here in our own neighborhood, and we had a wonderful response by Amish community who provided us in a very short order with tens of thousands of handmade cloth masks that we could then give to our visitors and caregivers in the early stages of pandemic. But this is just one example. The collaboration with industry goes, from Amish community that provides us with the masks to collaborating with the large airline companies such as United in creating safe environments for travel, or partnering with Clorox to develop the best products that would add to the hygiene and the better protection for our communities. And the list is very, very long, because this pandemic, just like it affects every single person, it affects every single business. And all of us here in this conversation have a responsibility that goes beyond the walls of our organization, the responsibility to share our knowledge and our best practices to the best of our abilities to all of those in need. And one of a really articulate need today worldwide is to create a safe workplace and to create a safe work environment. And while we are in healthcare and we do healthcare for a living, so to say, we've been living it our entire professional lives, that cannot be said for other businesses. So we have reached out. We have provided the best advice that we could provide based on available evidence, and we'll continue to do so.
So you just mentioned, PPE, and which we all, watching television all the time, we kept hearing about the need for more of that, more respirators. What did we learn? Talk a little bit about what the healthcare system learned, and hopefully the government agencies that work with you, so that we don't have that kind of an issue going forward. Dr. Klebanski, you want to take that?
Sure. I mean, clearly PPE was a critical issue discussed, I would say, daily. So internally, it made us look at optimizing supply chain. What did we do in terms of our hospitals? So that was sort of a given. I think the other thing it did was to not only have a greater understanding of the challenges of supply chain systems within our healthcare system, others around the state, And we were constantly helping other healthcare systems, hospitals, small community hospitals with their needs. But I think it also highlighted the exquisite vulnerability of supply chain for PPE overall. So many of us were looking to manufacturers in different parts of the country, different countries. The vulnerability there in terms of the supply chain system for PPE, I think was fairly stark. For a large healthcare system like ours, we were constantly prepared. We were going to multiple vendors, but I think it is a very fragile system. There are also the concerns of whether or not ventilators or other PPE would be diverted from other sources by the government, et cetera, and what that meant for us. So I think overall, it gave us a much broader understanding of the challenges of PPE. And yet we had so many of the same discussions every day on these calls. It was, I think, a terrific partnership that was developed among the healthcare systems in the state and beyond, again, in terms of the inventory, in terms of sharing PPE, in terms of looking for new sources. The state was very helpful, continues to be helpful in stockpiling. We also made some very interesting, I'd say, ideas that were brought forth from our own innovators around the system. And this relates to this innovation center of testing masks, looking at different companies for new types of masks. We also were able to forge a partnership with Battelle, setting up a decontamination center that Mass General Brigham stood up and that served a number of healthcare systems around the state. So overall, I would say new partnerships, working with industry, looking at our own innovators within the system, working collaboratively with other healthcare systems within the state and beyond. But the fragility of the supply chain and vendors, particularly some national, many international, I think is something we all need to collectively monitor. And I think we're all being extraordinarily vigilant about that going forward.
So how do we make those changes? Dr. Farrugia, the other day I heard a wonderful phrase, a crisis is a terrible thing to waste. Mm-hmm. And, out of this, are you confident that some kind of a national system will be set up so that smaller hospitals, for instance, that don't have the ability that maybe some larger institutions have to try to get what is needed, that from this we will see some kind of a system that will help every hospital in need?
So first of all, in a crisis, it's important that we never retreat from innovation. And innovation becomes really important. It's also important that we do not, in our zeal to move forward, forget the lessons we've learned. And we need to document them. So the fact that a just-in-time supply chain, as we just heard, doesn't work for a pandemic is important. The fact that a hospital that has to survive and to survive has to work at 90 to 100% capacity doesn't work in a pandemic is something we need to also be very aware of. From our standpoint, this is really highlighting that for us to transform healthcare, we need to step up, but we need to step up with partners. And the best partners are the partners that don't completely overlap our expertise, but at the same time share our values. And if you do that, then you end up with the ability to really move forward and really now make real the changes that we need to make. A good example is the COVID-19 Healthcare Coalition. This was set up, Mayo has been an integral part of it, but it's really 100 of organizations that came together and are sharing information about testing, about vaccines, about best therapies, created a dashboard. And in the dashboard, you can take all the disparate information and apply it to either your state, the country, globally, or even a county. It is essential that we continue to invest in innovation as a country. If we do not invest in innovation as a country, we will not transform healthcare. And so really what we have to do is take those lessons, make them real, make sure some of the changes at the government level in terms of legislature, in terms of laws get changed and the changes remain permanent. But then let's make sure that we continue to work together to embed these changes into the healthcare of the future.
So as I'm listening to you, do you have to strike while, you're still in the middle of a crisis to get, because sometimes it's like moving a mountain in order to get legislation passed that is needed. And so is it in this time that that push needs to be made?
Absolutely. Without a doubt, this is the time. We have fairly short memories, and therefore we have to do these things now. But then it's not enough to do them. Then we have to create new models of care and make sure those new models of care are sustainable. We have to create new knowledge using new tools. So bringing patients and data together to create new knowledge for our patients in a scalable fashion is something that we, and us three certainly, but the whole country, needs to really put our heads down and make sure that we're doing it every day now as we move towards hopefully the end of this pandemic, still a few months ahead, but as we move towards and then move into this new healthcare system that we all know we desperately need.
Dr. Mihaljevic, how do you balance risk and innovation in order to even change up what is standard operating procedure, but in order to ensure, safety, reliability, and better systems?
Well, we've been balancing risk and innovation our entire professional lives, and so have tens of thousands and millions of our colleagues before us. It is an integral part of everything that we do, and innovation is essential because it allows us to advance the science and help more people in need. And the risk is essential as well because we have to be able to face the risk. The way to balance it is through rigorous protocols and through rigorous oversight. And that is what we do in every clinical trials that we do with every clinical advancement of the science. And what is really, really critical here is to adhere to the best principles of introducing innovations in a clinical practice. There are no shortcuts. We're very much aware about the advantages of rigorous adherence to what we know are the best scientific practices. And when we do this right, we can see rapid advancement in science with the minimal risk that is associated as we march along. But that is really what this is all about. This is not a new skill. This is not a new requirement. The most important thing is with the best intentions in mind, we cannot introduce shortcuts in our efforts to either find new cures, to find new vaccines, or to introduce new ways that we deliver care. Those two things are not in contradiction. They're the same part of one process.
Dr. Farouj, I see you shaking your head, yes.
Yeah, without a doubt. Look, Tom said it, and I'm sure would say exactly the same thing. This is what we're built to do. Yeah. What we now have to do is make sure that the pathways that we've established, that we've shown to be safe, are made better by empowering people, as I've said, to bring new things in. And so there's a difference between empowerment and then making sure that it passes through the same rigorous quality control. And so you empower people, you test things, and then when they're ready, then you bring them through the same systems to make sure that they're safe. We've done this all our lives. We can continue to do it. And that is why the system is set up and the way it is set up is to allow us that degree of safety. I will say that this is the time really to think about ways that we can come together nationally and create a new national, not-for-profit way of running clinical trials so that we don't have competing clinical trials for COVID that are unlikely to fill. And Tom and I have been talking about this, and I'm sure Anne has been talking with her colleagues, about we cannot have 16 trials for a particular drug. We need to make sure as a nation we invest in the right things and then come together to get those trials to fulfillment so we know the answer.
And go ahead, Dr. Klebanski, a final word.
Yes, I would just say that what we're all talking about is really maximal impact, how we can have maximal impact on health, on patient care. And there is no shortcut in any of this. So the investments that we've made in basic science research, in understanding mechanisms of disease, in putting together digital platforms, all of these things have been deliberate. They've been factually based. They've been data driven. So if we continue that theme, keeping patients at the center of this, that is where we are going to move forward. Because I don't think any of us have fears that the things that we've learned individually will persist in our healthcare system. But the challenge really is, how do we take those things collectively? What we've learned in clinical trials, what we've learned about development of any new therapeutics, and bring this at scale in a way that makes this the most sense.
Well, we're all encouraged to hear the collaborative efforts that you all talk about. Doctors, Dr. Klebansky, Dr. Mihaljevic, and Dr. Firouzja, thank you all so much for sharing your insightful thoughts with us today at the Medical Innovation Summit. Thanks, everyone.
Thank you.
Thank you.